everybody. It's hard to believe that this is going to be our last DNH 142 official lecture. But if you can hear me, can you see if you can find the green check and say yes? Oh, yes, I'm seeing good mornings. All right. Very good. We've got a busy day today. I have to, at the end of this, we will be segueing into a whitening webinar, and then I'm going to have to leave to connect and make sure everything's okay for a webinar for the students. I don't know if it's you or second year that, or the graduating students for tomorrow as well. So I just have to be told to stop scheduling these things, I think. Anyway, we will get through this. So today we're going to be talking about the care of prosthesis. A number of you have already done the skill evaluation for that. You do have one skill evaluation that you need to do before you graduate. And my friends, you will graduate, and you will graduate on time. That's the plan. So just hang in there. We're working behind the scenes. And then we'll be talking about the end of the ADPIDE, you know, the diagnosis and the other part of it. So are there any questions before we go on? Everybody's muted, but I can, you can unmute yourself, I believe. Okay. We're going on. If I can figure out how my computer wants to work. There we go. So we've got our learning objectives, and I'm not going to go over them because you can read them yourselves. This is a fairly simple chapter, luckily. You know that you're going to be seeing patients with a little bit of everything in their mouth. They're coming from all areas of the world. They're coming from all socioeconomic statuses. They are coming from all different ways of wanting to restore and the importance of restoring things. So the overall health and cleanliness of the oral cavity really does involve the natural teeth, but also soft tissues as well as the dental prosthesis. So for our purposes, a prosthesis is an artificial replacement of a missing part of a body, or a dental prosthesis replaces one or more teeth as well as supporting structures. So our prosthetic can be removable or fixed. So awareness of the type and characteristics of these different things are important because you are going to be needing to evaluate the health of the tissue as well as the maintenance of whatever the prosthetic device is, and helping the patient to maintain these areas. So the issues that the patients are going to oftentimes ask you, especially when the doctor's not in the room, is they are going to be looking at you after recommendations are made by the doctor and looking at you going, do I really need this? Is this really important? So the more prepping you can do with the patient prior to the doctor coming in is going to be looked upon very favorably for you as the hygienist, because you have then educated the patient so the doctor can then just reinforce the recommendations. So daily maintenance, though, is going to be a vital factor, and that's where we come in, because we're going to, again, be educating the patient. So it's going to be something we are going to be coming in contact with multiple times during the day. So let's take a look at some of the different replacement options. I apologize. So a patient, again, can have one tooth missing or multiple teeth missing or all the teeth missing. And it's up to us to inform the patient of the replacement options. Now, sometimes they can get away without having anything replaced. A lot of people do. But again, we're looking at optimal uh, chewing and health for the patient and maintaining that bone integrity of the maxillary and mandibular jaw. So we want to evaluate the patient and provide objective information for them on alternatives for treatment. Not everybody is going to be fitting into the same box. And we have to give them the alternative so they can choose what's best for them. And sometimes what's best for them is not what we would decide. But again, we just have to be impartial. So you're looking at the patient and providing the objectives for them. Where are they in their decision-making process? Not everybody is going to want to replace their missing teeth, and not everybody's going to want to replace them immediately after a tooth needs to be extracted or is lost. So replacement options include fixed prosthetics, removable prosthetics, dental implants, and we're going to be talking about that later on. And our role is to explain each possible choice for the patient as well as clarifying questions for the patient. We want to prepare the notes from the patient's medical and dental histories, look at the risk factors. We're doing the EOIO, and again, making our best determination. But we need to keep a neutral stand on the options until the dentist has really studied the case and advised. We might be really pushing for an implant because we know that's the best option, but there might be other things going on, the integrity or quality or amount of the bone, or where the sinus cavity is, or something's going on that might not make that the best option for the patient. So again, we're giving options. And one of the main options, again, is no replacement. Replacement of missing teeth might not be indicated for somebody who has sufficient teeth that they can use quite naturally and normally and not be affected by it. So if I was missing, for example, number 16 or number 15, and I didn't have number 16, and I can live quite nicely without replacing that tooth. I might want it replaced, but would I really notice the difference? I don't know. I'm not planning on finding out. So that's always an option. Third molars are generally not replaced after extraction. We used to try and save third molars if, for example, the first and second molar were in jeopardy and we needed to place a fixed bridge. There are second molars that are extracted that don't have any opposing teeth. Again, patient is going to be able to survive quite nicely without replacing a tooth. And teeth are extracted for orthodontic purposes. They don't need to be replaced. They are also going to be reshuffled. So the extraction site hopefully is going to be closed up. But risks of not replacing teeth is the migration of adjacent teeth. You know about the tilting and the rotation of teeth. It takes very little time for things to start shifting, 24 hours. In fact, remaining teeth can suffer from the added function and stress that may lead to occlusal discrepancies as well as future tooth loss and fractures of the teeth. Because our mouth, the occlusal load is meant to be working in harmony. The loss of occlusal vertical dimension. Now, if you remember back to oral anatomy, that was one of aesthetics, and vertical dimension was listed for every tooth class type. But the bite might be overloaded because of certain missing teeth, and that can also lead to some TMJ issues. Then you've got your loss of vertical dimension, you've got angular cheilitis that could be resulting from that, and the pooling saliva. So no replacement is an option. It's not generally the best option, okay? But we always have to give that as one of the options for our patient. Then we've got our fixed partial denture prosthetics or prosthesis, and that's commonly known as a dental bridge, and it's composed of an abutment, connectors, and pontics. And there is a table in the book that has the different types of prosthetic devices. So if you are familiar with the different options that the patient has, these are just the names of some of them. So we're talking right now about the partial denture, the fixed partial denture. And this is a picture of it. This is a partial denture. I've never called it a fixed partial denture. It's always been a bridge. And the bridge is classified according to how many teeth are involved. So they're missing one premolar up on the top. And with a fixed bridge, you have to have abutment teeth. So the tooth in front and the tooth behind are prepped, and crowns are made, and you've got your pontic, which is the floating tooth. The pontic is connected. So this is a 3-unit bridge, and the patient can't floss regularly because everything's connected and they need a floss threader to get underneath. The other option is a cantilever bridge, and that's B, cantilever bridge. So they're missing one tooth. It's, in this case, it is the molar, the first molar. So what they do is they prepare the 2 teeth, sometimes even more in front of it, connect them together with the floating teeth in the back, the tooth in the back. Now, oftentimes, if it's a molar that is being cantilevered, that floating tooth is just about the size of a premolar, right? Again, it has to do with trying to equalize that occlusal load. You can also have fixed bridges with implants, and that's what C is all about. And D, the bottom one, is called a Maryland bridge, and we'll be getting into that, and that's a fixed resin retained partial bridge. It used to be very popular, and it is minimally invasive because you're really only taking away a little bit of the enamel on the lingual surface. But you have to be very judicious in where you are placing that. Can you imagine that the strength in between? Okay, compare the two. Here you've got D, which is your Maryland bridge, or A, which is a 3-unit bridge, which is going to be stronger. Okay, obviously A is going to be stronger. So those are our different types of fixed partial dentures. So we've got abutments, connectors, and pontics. And a bridge can be fabricated with different materials, metals and ceramics, just ceramics, or a combination of both. And a fixed denture is affixed to the teeth or implants with special cement, and that's not removable. So they need to be able to clean around those 3 teeth. There are natural supported teeth. That's the bridge. Okay, that was picture A. Then you've got your cantilever, where you've got 2 crowns connecting, and the floating teeth. And then you've got your implant supported, which we're going to be getting into a little bit more, but all require special cleaning. The patient can't floss those areas, and sometimes floss is not the best option for them either. So you need to know what options are available for the patient. So the care for the fixed prosthesis, first off is what's really good is an oral irrigator that is recommended oftentimes, because that can remove the loose debris throughout the dentition, and that's a good first step. And that facilitates the biofilm removal with the toothbrush and other aids, because there just isn't the leftover stuff in there from the meals before. So it makes the toothbrush, allows the toothbrush to be a little more effective as well. Then you've got your normal biofilm removal, and that is going to be your toothbrushing as well as your flossing or proxibrushing. And for this, the proximal surface of the abutment teeth and the gingiva around the pontic really needs special attention. But for toothbrushing, you're using the traditional Bass method or modified Bass. You're using a circular brushing technique with a non-abrasive dentifrice because you don't want to be scratching any of the porcelain or irritating the tissue. You need fluoride containing toothpaste because you want to have that fluoride protection around the margins of the crowns. Now, speaking of fluoride, you want to stay away from acidulated phosphate preparations, the APF fluoride, because again, the porcelain and composite, it can etch that. Toothpaste and home preparations are generally a neutral sodium or a stannous fluoride. But you need to be thinking outside the box sometimes with the interdental care. Removal of the biofilm and food debris from the proximal surfaces really is vital. And some patients are going to be seeing you after having a bridge in their mouth for years and looking at you with a straight face and telling you, I've never been shown that, when you're trying to tell them about a Proxibrush or Superfloss or something else. It's just astonishing. Now, it's not that they've never been told. I'd like to think that it's just was never in the forefront of their mind. Just like students, say, I've never heard that before, when I know you have because I was the one telling you about it. So patients are like that as well. Or you've spent a lot of time discussing different alternatives for the patient, and the doctor comes in and they're looking at the doctor like this is the first time they've ever heard it. You just want to smack them. So be patient. It takes repetition, right? And we always want to be as positive as we can for the patient. But the same interdental cleaning procedures that the patient might be used to or even never heard of might need to be altered around these prosthetic devices. So it really requires emphasis to keep these areas clean. Restorations may provide more plaque retentive or biofilm retentive surfaces. And if there's a biological width issue involved there, there's going to be inflammation that no matter how good the patient takes with their oral hygiene just isn't going to be resolving that inflammation. So you want to take everybody, we've got the same spiel for everybody. We know what we want them to be doing, but we have to sometimes be a little creative on the specific devices. So we're talking toothbrushing technique. The methods were usually is going to be the Bass or modified Bass or Stillman's. Okay, we want a circular brushing technique. We want short wiggles, which is why I like the Bass, because it's a back and forth wiggle instead of circles, and because I'm a wiggler, and the bristles can then conform to the gingival area. Sometimes for dental flossing, you always need, depending on the amount of space, a threader. There are some circumstances where there's enough space that the patient can just poke it through, but that's not usually the case, or some sort of tufted dental floss. And the flossing is, you know, the flossing technique, about 15, 18 inches, and there's several types to choose from. And they need some way to get underneath the pontic. So the thing that's important with the dental floss is the patient needs to take a new section of floss when they go from one tooth to another. So they're always moving that floss around to a clean section, because we don't want them transmitting the pathogens that might be in one site and inoculating another site. So if flossing is not the best for the patient, then we're looking at the interdental brush or the Proxibrush, or maybe even an end-tuft brush. And you have some of those in your kits. Other factors to take a look at are the margins of the restoration. We're always evaluating those margins. We're looking for cement washout, we're looking for leakage, we're looking for decay. We are the ones that are going to find this at its infancy, more so than a radiograph or the dentist, because we're working around those margins more intimately with our instruments. So we're looking at things that might need to be re-cemented or repaired or replaced. And we always want to tell the patient, what's going on. Was the queen in one office of pulling or popping off crowns. It wasn't that I was doing anything wrong, but the one associate dentist was not the best clinician, and there were always open margins. And I would, if the crown came off during the cleaning process, the patient's looking at you. Oh, what did you do? And by the odor, you're telling them this crown has been loose for some time. Aren't you glad that it came off here? So you're always trying to spin things. So anyway, customizing what the patient's doing according to what's in their mouth. So now those are the fixed options. Let's take a look at the removable dental prosthesis. Now, again, you do have one skill evaluation that needs to be done before you graduate on care of a prosthesis. That can even be an Invisalign aligner. It can be a retainer. It doesn't need to be a partial denture, right? So we call them RPDs in some offices for removable partial denture. Each office is going to have their own way of charting them. The more computerized we go, the more standard it may be as well. But a partial denture can actually be removed from the mouth and replaced at the pleasure of the patient. The denture base rests on the oral mucosa, and that's what carries the artificial teeth. And a typical denture consists of a stable metal framework made of chrome cobalt. Okay, it's usually metal. They're coming into some hybrid acrylics as well now, but the framework engages the abutment teeth or the abutment implant with a variety of clasp assemblies and rests and precision attachments, so it can actually clip in to the patient's mouth and be a steady force there and not pop off during eating or talking. So depending on the location and the number of remaining natural teeth, a partial denture can receive all its support from the teeth, or maybe partially tooth-borne, partially implant-borne, and partially tissue-borne. So it depends on what the what's in the patient's mouth. But the base is made of plastic acrylic resin. That's that pink material that we see. And the teeth are made of porcelain, which can be very heavy, plastic resin, or sometimes even metal. So the basic parts of the removable partial denture is on figure 32.4, and that's coming up. Let me see if I can find it. Whoops, going in the wrong direction. There we go. Okay, and this is a classic. So you can see which teeth are missing. The patient has no first, second molars or second premolars, and they do have their laterals. So you've got your clasps, which are the little claws, and you've got an occlusal rest, which looks like a little button or a flat section that actually goes on the occlusal of a retained tooth. But all of that, think about all of this being a plaque retentive surface, okay? It's getting a lot more surface for biofilm to want to adhere to, and especially between the tissue and the metal and the acrylic, you've got that warm, dark, moist area that is protected by the overlaying of the metal and the acrylic, and it is just a feeding ground for bacteria. So the patient needs to be instructed on how to care for this properly. So the health of the underlying tissue can really be negatively impacted, and we have to have the patient take this out during an EOIO. We need them to take it out most of the time before radiographs or a panoramic. But think about the patient also that you need to take an FMX with, and you need to take the opposing arch if they have opposing teeth. Then you'll want them to oftentimes have, when you're taking the mandibular arch, for example, have them keep that prosthetic device in on the maxillary, so it gives the patient something to bite down on with the bite blocks. Sometimes you can use cotton rolls and other devices as well, But sometimes, oftentimes when you're taking radiographs with these patients, you're doing a flip-flop on what they're wearing. There are times also for full dentures where the dentist will be recommending that you take a pan or something that has the denture or still in it. And there are instances where that happens. But biofilm is going to be a major factor. So we need to provide the patient with adequate education on how to maintain these areas as well as the tissue underlying them. So they need to still be coming in. Even patients that have full dentures, no teeth in their mouth, still need to be going to the dentist for an evaluation and an exam. This is every 6 months, every year, depending on what the condition of the patient is. I usually would still have them in the hygiene room. They would give me a half hour versus an hour for these patients, but you would check the fit of the dentures, you would clean the dentures in the ultrasonic cleaner, you would be doing an oral cancer exam, and then the dentist could come in and check for everything. Patients like their old dentures. They feel comfortable. It's like your slippers that you wear around the house. And they might not even be fitting well. Sometimes they're big and clunky, but it's their comfortable shoe. And dentures wear down. They're acrylic. The teeth wear down. And if they're not functioning properly anymore, then the patient, it happens so slowly, the patient isn't aware. So that is one of the things that we're also looking at, because every time they bite down, they are using their muscles, they're putting strain on the ridges where the missing teeth are, and that ridge can be forever changing. So when we're cleaning, we want to make sure that we're not damaging the denture at all. So we're having the patient take it out, we're putting it in a baggie in front of them, we're giving them the baggie, we're holding the baggie, they take it out and put it directly into the baggie. Now, oftentimes you're giving them a tissue too, but they don't know how to use, they're used to using their fingers, so they just put their fingers in their mouth and take the denture out and put it in the baggie. Then you want to make sure that they're using some sort of hand sanitizer afterwards. Because we do want to prevent cross-contamination when receiving and giving, and we don't want the patients to have all of that saliva on their teeth, especially if they still haven't signed the appropriate paperwork yet, be it, however, paper or computer. Patients oftentimes will they'll sit down, and immediately the first thing you do before you can even say good morning or good afternoon is they've got their hands in their mouth and their denture is in their fingers. But we want to always be ready for them before they come into the room. And we want to, after the baggie, the prosthesis goes in the baggie, we rinse it off, and then we place the cleaning solution in the in the baggie, and then that goes into a beaker which has fluid in it, water, and then the beaker goes into the ultrasonic device, okay, because we want to protect the denture from ultrasonic cleaners in case the baggie has a leak. We don't want the ultrasonic cleaner to be leaking, seeping into the baggie, because that is going to go back into the patient's mouth, nor do we want harmful chemicals being used. And the ultrasonic bath has those harmful chemicals. So we are going to be very careful on how we take care of the removable partial denture. Now, one of my stories is this was years ago, back in the 80s. They came in these big jugs, gallon jugs. We called it tartar and stain remover. It's still called tartar and stain remover, but it's a gallon jug. And guess what? The ultrasonic solution came in a big gallon jug too. And the names were where the handle was the back, and the names were always in the front. And somebody had reversed the ultrasonic solution with the where that was normally housed underneath the sink in the lab, with the denture, tartar and stain remover. They were usually in a separate section, And I wasn't thinking, I did not look. I put the ultrasonic cleaner in the baggie, cleaned the denture with the ultrasonic solution, and what it did was it didn't harm the denture, but my employer wasn't happy because the metal wasn't that nice shiny metal anymore. It wasn't pitted, but it had a little patina on it and a matte finish. So my employer had to spend a few minutes in the lab buffing all of that up before we could go back to the patient. I did document it in the chart, and I did tell the patient about it. I was horrified because when you are a type A personality, you don't make mistakes like that. Well, guess what? We do make mistakes like that. So we've got our removable denture. If anything is removable in the mouth, we want the patient to be taking it out of their mouth. We would love for them to take it out of their mouth for 12 hours or more. Now, sometimes patients don't ever take anything out of their mouth. They don't want their spouse or their significant other or their children to see them without certain teeth in their mouth. Sometimes they say people don't know, their significant other doesn't know they have what's going on in their mouth, and it's just uncomfortable, especially if they have opposing teeth. It's uncomfortable for them to keep it out of the mouth, but we have to encourage the patient to try and take these out of the mouth at some point during the day. If it's not at night, then we try and come up with other times. If it can't be for 8 or 12 hours, then maybe multiple times during the day when they're in the bathroom by themselves, or they're taking care of their teeth, or they're in the shower or whatever. Have that be the time. So that allows the tissues also to rest and get the circulation back, and it allows time to also clean the denture. But that is like wearing a pair of tight-fitting socks or tight-fitting shoes all the time when you have something in your mouth like this. And you know, when you take your socks off after clinic, you might have a little ridge. You young ones don't know this, but you have a little ridge where the top of the sock was, right? And the same thing happens when you have a denture. So we're being very careful. So we are telling the patient what they need to do. We are educating the patient on what they need to do, and we're encouraging the patient on what they need to do, because these are all coming in different steps for various individuals. So we want the patient to be rinsing, especially with removable dentures and regular dentures after each meal. They might not be able to go into a public restroom. We don't want them doing that, taking their teeth out and stuff, but swish and swallow, swish and spit, something like that to remove the loose debris. Because again, with all the architecture in the mouth, there are hiding places where food likes to collect. So we need to be telling, educating, and motivating them to take care of not only their natural teeth, but the prosthetics involved. There are a lot of different cleaning brushes that can be used. This is a Clasp brush. This was more popular back in the day, so to speak, but you can see because of the clasp and the occlusal rest that it's difficult to get a regular brush in there. Sometimes a regular toothbrush can fit in there nicely, but these clasps can be thin. They can be wearing thin if they're old, and so you want to be very careful. This is a triangular or a cone shape brush. The bristles of the brush are a little stiffer than what's on a regular toothbrush that the patient would use inside their mouth. So it's got a little more cleaning capabilities. But that is a breeding ground for bacteria there. But it's a special brush. Does your patient have the real estate on the bathroom sink to want to have all of that? We don't know. We don't know. But they have also denture brushes, which we're going to be seeing. We don't have denture brushes in the clinic because we have to buy them and we don't have the money. So what we're doing is using a patient's toothbrush. We're bringing the toothbrush, we're using that, and then we're giving the patient the toothbrush that we've used. So they do have specific denture brushes, and they're usually double-ended as far as one end is the handle, but then it's got two different types of brush heads at the other end. One is a very stiff, bulky brush, and another one is more tapered to get into where the denture rests against the ridges in the mouth. But a patient can also use their power brush if they have the dexterity on their prosthetics. If they have their Braun or their Sonicare that they're using, or their Oral-B, excuse me, and their Sonicare, they sometimes like using that on their removable dentures as well. And it does do a nice job for that. But denture brushes are usually what's recommended. Your office will probably have something. If that's the case, you get a fresh denture brush out. You clean the denture, you brush the denture in the lab sink, wherever the ultrasonic is, and then you carry that back in the baggie with the brush. And the baggie usually has a little bit of mouthwash, or the cup has a little bit of mouthwash, and then you give the patient the brush. Now, in the 70s and 80s, when I first started out, we weren't doing that. We had the brush sitting in a coffee cup or a coffee mug on the counter of the sink in the lab. And you'd use that, and then that would go through the autoclave, and then after, you just have a collection of them. We didn't reuse it patient after patient, but they weren't in bags. Ew, right? Now, there are patients that are going to have something called obturators. You're not going to see them very often, unless you're working in a perio office or hospital practice, or one of the periodontists that I worked with, I wasn't there full time, I was just there on Saturdays, but he had a lot of cancer patients. And so you might be seeing obturators. And those are things that will, say a patient has a cleft palate, and they have a hole in their palate, and it's not surgically able to be closed. All right, every time that patient eats or drinks, you need that hole in the palate to be closed. Otherwise, all that food or fluid is going to go up into the patient's sinus cavities. So they have these removable obturators. The patient, oftentimes you'll hear them talking with a little bit of a lisp, or they sound nasally because it's not a tight seal sometimes. But you can also have them take that obturator out and put that in the baggie and clean that like you would a traditional denture. But it does require professional maintenance. So if you're working for a prosthodontist or a periodontist, you might be seeing patients more at the beginning stage. But then for the maintenance stage, these patients will be coming to you in their private practice, to the general dentist as well. So don't be afraid of those obturators. They do have a unique odor to them when you take them, when the patient takes them out, but it's something important that we do for our patients. So this is what a hole, for example, will look like in a palate. And then the obturator is something, now this is an obturator and a partial denture for this particular patient, because you can see that they're missing that right molar here, right? So they're replacing a tooth there, but it's filling up the hole. And sometimes it doesn't have clasps around it either. It just looks like a sink plug, so to speak. So when you're cleaning the teeth, you want to make sure that you're not getting debris in that hole as well. So the first couple times you see this, it's going to freak you out. And don't let it. The patients are very understanding, right? And you'll be seeing patients with complete dentures. There are various types of dentures. You've got an immediate denture. which is the initial placement after the patient has their teeth extracted. They get an immediate denture. And that is more like a temporary denture. It acts as it temporizes everything until the ridges, everything heals. And then final impressions can be taken for the real thing, right? But we have to have the patient be able to chew while everything's healing as well. So we need to get the entire dental team involved, because this is going to be going on in the back of the office. They're also still going to be seeing you as the hygienist. New complete dentures are time taking and very painstaking for the dentist. The patient comes in multiple times for fittings to make sure that the size of the teeth and the placement of the teeth are right. And the dentist will also have the patient say T, say ta ta ta, S S S. They'll have them go through those difficult letters of the alphabet to make sure that they can articulate things properly. And then they need to come in for multiple adjustments as well. So an immediate denture is not meant to be long-standing. We will be seeing patients in our practice and in clinic that have their immediate or temporary denture 5 years down the road. They just never went in for whatever reasons to be able to get the complete work done. And the temporary dentures don't have the substance of the materials. They tend to wear thin. So again, sometimes you'll be taking a denture and you'll be seeing that the teeth aren't really teeth anymore. You can see the pink from the resin. They've worn down so far. So you know those are the patients that don't have the vertical dimension that they originally had, as well as the chewing capability of the food, and they might have temporomandibular joint issues as well. So dentures will attract biofilm just like natural teeth, sometimes more because the acrylic is not as smooth as the enamel. And again, you've got all that surface area. So where you've got biofilm, you also have calculus. So you are going to be spending time, sometimes more time, cleaning dentures than you do any natural teeth that they might still have remaining. So this is one reason why sometimes you'll see a completely edentulous patient. You'll get, like I said, the 30 minutes with them, but I have, yes, taken an ultrasonic with a beaver tail, a flat instead of a pointy insert, and scaled the dentures over a sink, just like you would be scaling the denture or the teeth in the mouth. So again, you don't want to scratch anything, okay, because that will encourage biofilm as well as stain. So you need to be careful on what is what's in the denture. A lot of times the denture will have either denture paste or some sort of adhesive to it. They have soft liners or tissue conditioners or permanent soft silicone liners. We don't need to know all of that, but sometimes there is a little bit of a cushion, and it's not just the acrylic or the resin against the palate or the ridge, and that helps with adherence of the denture as well as giving it a little bit of stability and comfort. So that stuff is supposed to be there. Denture adhesive is commercially available in a paste or a powder. It is a pain in the neck to get off if the patient comes in with that, but we get it off. It's very gummy. We get it off, we clean the denture, and it's important that you have some denture paste in the room. You can put a little bit of, the patient can put the denture paste on their denture, place the denture back in their mouth, and you give them the tube of denture paste. Companies like GlaxoSmithKline will have, that's the Fixodent, will oftentimes give free samples of those for your offices, so you don't have to purchase them. So we are in charge of cleaning the denture. We want to, when the patient leaves, we want everything to be clean. So again, we're rinsing everything off before we actually clean them because there's food debris, there's mucin as well that adheres to the denture surface. The denture cleaner in the ultrasonic will oftentimes loosen everything up. It doesn't remove things, but there are enzymes to help soften. So that's where a denture brush really comes in handy because it's a stiffer brush. Again, we don't have them, so we're trying to do things with our soft toothbrushes. Calculus is going to form on them as well as stain, and that will happen on both removable and fixed dentures. So we need to know what's going on in the patient's mouth. Right? So we clean by immersion, okay? We're putting it in a baggie. The baggie has a solution in it, and that's going in the ultrasonic. And that's softening everything up. Then we're brushing. We're taking it out. We're rinsing it, and we're brushing it, right? There are specific cleaners that can be used, denture cleaners, that tartar and stain remover, for example. We also have Aphrodent, or those tablets that can be a powder that you put in a whole pouch of powder in, or a scoop of powder with warm water, and that has the enzymes in it as well. These things usually don't taste very good, so it's imperative that we rinse things really well. That's why it's nice to put just a little bit of mouthwash in the sealed baggie for the patient. Now, when you're in clinic or in the office, it's important also that you label the baggie, or with somehow have some labeling so you know whose night guard is in the ultrasonic, whose denture, what room, that type of thing. Especially if you've got two spouses, a husband and wife, that are coming in at the same time, or two kids with retainers. They're going in oftentimes that same ultrasonic bath in separate baggies, but you don't want to get them confused. So we're labeling things. And we're also taking a look at things to advise the patient on anything else they can be doing. But we need these dentures out when we are doing our exam, because we're looking at the underlying mucosa. We're looking for any sore spots, red spots. We're looking for denture dermatitis, or the all those little red dots that the patient can have. And oftentimes you can see the outline of the denture, like you can see the outline of your sock when you take your socks off, because of the pressure there. So we want them to be able to take this denture out, massage the tissue with their finger or with the soft toothbrush. That massaging will remove a layer of bacteria, but it also stimulates the circulation there. And they're using the brush to cleanse and massage the underlying tissue. There is something called an overdenture. We showed you that also in, I believe, in another chapter, but this is where a denture actually clasps or clips on to, see if I don't have a picture of it. We'll have a picture in another chapter, but they actually have clasps where either the canines or other teeth are root canal therapied, and then they make them, drill them down into little buttons, and then the denture can actually clasp onto that. It gives, especially for the mandibular arch, a little more retention. Mandibular dentures, removable dentures, just never work right because the ridge disappears, so there's nothing to hold on to. The maxillary denture, things have a suction with the shape of the palate, so that has some self-adhering properties to it. So you might have a tooth retained overdenture or an implant retained overdenture, and these are things that the patient can remove. Some of the implant retained overdentures are fixed, and they have, it takes you 45 minutes just to figure out how to clean those things the first time you see them. But you might be seeing them as well because the patient can't take them out. The prosthodontist can, the dentist can, right? So sometimes you'll have appointments in tandem where the dentist can also come in, take that out, and you can clean everything and then they have to have it placed back in. So it takes some coordination with the front desk with appointments with that. Similar to if your child goes in for an orthodontic appointment and they take the arch wire out. Sometimes you'll have them make a cleaning appointment. They'll go to the orthodontist, the arch wire will be taken out. They'll go in and get their teeth cleaned with you, and then they'll go back across the street and finish their appointment. It just makes things so much easier. So we are educating our patient. We are demonstrating. We are having them demonstrate back. We are always having them demonstrate back. Show, tell, do. Especially if it's a new denture wear, they need motivation and our continued guidance, as well as affirmation that they're doing a good job. Don't worry about it. You know, we're here for you. A fluoride program is really critical if they have retaining teeth, because oftentimes there's recession where the bone has resorbed around the missing teeth, and you've got newly exposed root surface. They also have all of that hardware in there with the surface area that is plaque retentive. Sealants, depending on where it is, what's going on, you can still recommend sealants for adult patients if they are caries prone in certain areas. And again, the importance of maintenance procedures. So we are really not treating anybody differently that have dentures. What brings you here today? Well, I haven't been in a year, and I was told even though I don't have my teeth that I still need to come in, and we're happy to see them. But we are looking at the stability of the dentures and the stability of the existing teeth that are in there, because those are what is taking the brunt of the occlusal load, and we're doing a very comprehensive intraoral exam. Okay, so we're always teaching our patient on why it's important that they are coming to us and the importance of their visits, as well as re-educating them and reaffirming the need to replace certain missing teeth. If something breaks, you want to have them come in. Don't let them repair or adjust the denture on their own. We've got patients that have taken nail files and tried to even adjust their own teeth in their mouth if something has chipped and it's sharp. So it's not unheard of that they go and find the super glue or Gorilla Glue and put something back on a denture themselves. Not to say that you'll never see that in private practice either. You will. Things aren't being resined and holding together. I have seen certain things that I don't want to see, and you just question it in your head and move on. If it works, it works, but it's not our decision for that. It's the dentist using the education that they have and the means that they have available to them. So that really is the care of prosthesis chapter. Are there any questions? Okay, what we're going to do, let's take a 5-minute break. We're going to come back and we will continue on.